Thank you very much. Thank you. First of all, I would like to thank you, all my friends, for the big steps we've been going through the history of computer-guided implantology. It's been starting a long time ago in the early 1990s, and I was in touch with Luc, and I have been learning a lot from Luc. And when we called each other a few weeks ago, because they asked us to make the same lecture all together, it was like we were still seeing each other with no stop since that time. So the science has to improve. We never stop. And Luc, are you going to talk to us about the beginning of this story?
Yes. The really beginning is 1992 already. So it started with whatever. Is it working? It started in 92 with an article of Philippe about the planning of an implant. And actually, we will talk today more or less between 1992 and 2005. This is really the beginning. After 2005, you have your organization, which came up. But so it's a period of 10 to 12 years in the start. And I will try to explain how it all came, because it was not a straightforward development. You have to remember at that time we had an analog OPG, and the only thing we could do on an OPG is to calculate the height with a ruler, and there was no way to know the thickness of the bone except by good old clinical examination at that time. And then we had the first CT images, and in the beginning with the CT images we only could make an arch. And we could make a big arch and a small arch, and then we got cross sections like sequential orthopantomograms. And this was really the beginning. That's how we also did planning of implants. And then later on we had the DentaScan, and the DentaScan allowed us to make cross-sectionals, meaning perpendicular slides on the OPG, and on that moment we could measure the thickness of the bone. But again, there was no digital way. We had to measure it with a ruler on the photo, and then we knew the thickness of the bone. And then came Simplant, and I think Simplant was one of the first, maybe the first or one of the first programs which was digital. It's 99, the first digital program. And on that program, we were able to measure the thickness and the height of the bone. We could even plan an implant, but at that moment, an implant was only a cylinder, nothing more than that. But we could at least do a planning, but there was no way to bring that planning to the patient. We could look at the computer, and then we started operating. And then we have Simplant, which was acquired by Materialize. And on that moment, we were able to do the planning, not yet a drill guide, but we had the first 3D image, like this one, only in one color. No way to do a segmentation. You had to both jaws, and then you have to look where can we do something. So this was the beginning of 3D. It's 2001. It's not so long ago. Then we have Materialize coming on the scene. And Materialize was actually a company making 3D parts for the automobile industry. They were making parts. They were very good in printing. And on a certain moment, they had an idea, and they say, well, we can print almost everything. Should we not be able to print body parts, parts of the skeleton, of the skull, of the cervical spine, or the pelvis, or whatever? So they made a project, and I think this got a funding from Europe, and this is called the FIDIAS project. And I think the whole computer science we have today is really also sponsored by the European Committee. We don't know that, but actually they spent a lot of millions just to have this thing developed. So the project went from 1998 to 2002. And once the FIDIAS was underway, so the FIDIAS was really printing a skull, printing whatever, cervical spine. And then they had the idea, well, couldn't we make a drill guide? And in theory, what is a drill guide? You have the bone, and on top of the bone, you have a structure, whatever. And that structure has to rest on the bone with legs or with surface contact or whatever. And within the body, you have cylinders, and with that cylinders, you can make drills. So this is the abstract concept. And then you have Materialize, which is a professional company, and they say, okay, we want to do that, but we have to validate it. Each step has to be validated. If we ask a drill guide to our dental laboratory, it's not validated, of course, but here it's commercial, so the requirements are very high. So they had to do a lot of rounds testing. And they tested the 3 structures I mentioned. The first one was how accurate is the printing. And at that time, they used SLS, which meaning selective laser sintering, which means they have the powder, and this is with the laser, it's solidarized. Now we do everything with stereolithography, but at that time it was SLS. So they had to measure the accuracy, and they did that by printing such a tripod device, and then they measured the deviations between the central pin and the green pins, and even with the big structure, they had deviations from 0 to 1.5 millimeters. So they proved that this was a good substance to make a structure. But that structure has to be sitting on a bone. It's a mandible or it's a cervical spine. Here they chose the cervical spine because it was the most complex anatomy they could imagine. So they took the real challenge. Let's make something difficult. So they made a structure which rested on the processes of the cervical spine. And again, they saw that it was very precise. And then finally, we have the structure, we have the legs, the support, and then we have the tubes on top of it. So they made a structure with tubes, and then again, verifying everything, and it proved to be very accurate. And all those tests were done not by Materialize, but by an independent university in Leeds, by Professor Cuponi, and it was really demonstrated that the whole chain they wanted to do was accurate. So everything was in place. So they tested the feasibility, and now they wanted to go to clinical examination, and the clinical examination was, let's make models and see if the surgeon can do something with that kind of models. And here we have an example of Professor Schoenaerts in Leuven, who used the printed skull just to do complex craniofacial surgery. And you all probably remember the images of the Siamese twins, which operations were actually also prepared by stereolithography to know where they had to cut the bone. And then they went on with the University of Amsterdam. They did reconstruction of defects in the frontal bone, and then also reconstruction of orbito-maxillary defects. And now for Materialize, everything was ready. We are now 1997, so we have a new project coming up. It's the pizza project. It has nothing to do, Guido, with the Leaning Tower. It is not like that, but it's really personalized implant and surgical aids. What does that mean? They have the technology to print a jaw. They have the technology to make a planning because they acquired Simplant and they know where to put the implants. and they have technology to transfer that planning to the patient. So the circle is round. So everything was tested, and this is really the first, I think, scientifically tested and validated drill guide. It's a little bit maybe old-fashioned today, but it's really the first step for a very complete preparation. Philippe, do you remember the first patient?
I know that he did the first ever patient in the world using a surgical guide. And you're going to show it?
Yeah, sure.
Okay.
Well, the first patient is nothing impressive because nobody has worked with stereolithographic guides at that moment. And we happened to do that. And I was in a private practice. I was not at the university in Leuven. And Materialise had been working with Leuven. So they asked at the university, would you please test it? But they were so slow in deciding. It took them 6 months. And then afterward, Materialise said, this takes too long because we have investments going on. We have to do something. So they were looking to periphery centers. And one day they came, they got a phone call, and they came to explain their project. And you know what? I was the first to say, yes, I do. I want to do that. Okay. But I said, I have never done that. It must be a simple case. And if it goes wrong, I do it my way. Then I agree to do it. That's why it's not a complicated case. It's the most banal, simple case, but I needed to have a fallback because nobody has done this before. So this is the patient, a mandible, and this was the proof of concept, meaning that the concept they made works or not. But it did work, of course. So they prepared a 3D model of the jaw, and we wanted to place 2 implants. You see, very, very simple treatment. On top of the model, you see a stereolithographic drill guide with tubes, and they had only one diameter of tubes, 2 millimeters. So you can use it for your 2 millimeter drill, and then you go on. This is the operation. And finally, it was there Tuesday, 26th August 1997. This is the day the first patient in the world was treated with the stereolithographic drill guide. And you see that drill guide. It has no retention pins at that moment. We didn't think about that. So I had to push with my finger the drill guide on top of the bone and make the drillings. So it's very simple, but it worked. We did the drilling. It took just 2 minutes to do the operation, but it's the culmination of many years of preparation. So we have that in that day, 26 August, and I think it should be a holiday almost because it's this year, 25 years ago. 25 years ago, we did the first patient.
And it was not an easy case, but if you can see the bone, there is a narrow edge of bone. Yeah. So it could have been sleeping outside or whatever. Yeah. But you maintained with your finger, huh?
I maintained with the finger. Now we would do alveolectomy or whatever. So it would be a slightly different treatment, but with immobilizing the drill, we were nevertheless able to put it, and I planted them quite deep enough for that. So the drilling was done. Then we inserted the implants the usual way. We took the impression, and this is a photograph, OPG, 13 years later. The patient died in 2020, so she had 23 years after treatment. For 23 years, the implants were good, photo was good, clinical examination was very good. So we have seen application with bone-guided drill guide, but this is how it started. But then we had a challenge with Philippe. How can we do that in a transmucosal way? And how did you do that, Philippe?
Okay, the issue is that we could work only with guide laying on the bone. We could do anything else. We were not talking about partial cases. We were not talking about full cases on the mucosa. So what happened, and I've been working on that, I started trying to find out the way to create a scanographic guide to show the teeth. instead of putting something in metal inside the teeth, I used to make holes, okay? And we started like this. And then we went to a different one. We take a copy of the existing denture, and we are making a new denture, which is a scanographic appliance with holes in the middle of the teeth and two different layers of density of barium sulfate. So the first one is 30% for the teeth and 10% for the base plate. Why do we need to make 30 and 10? We've been trying 5, 10, 15, 20, 25, 30. I did that with my daughter, who is a lab technician, and we've been checking all to end with these two values. We call that a gradient. There is a big difference in between 10 and 30, and this allows us to make two different masks, a mask of the teeth and a mask of the base plate. Why a mask of the base plate? Now you know we will see the surface of the mucosa, which will be exactly the same as the underlying surface of the base plate. And this helps us to allow us to work on the mucosa. Before, we could not do it. So we are working like this, and I made a publication with Luc at that time. So we have a mask of the teeth, a mask of the base plate, and then we can plan implant. In this case, some zygoma implants were planned, some pterygoid implants were planned, and some anterior implants were planned. This was in 2001, and this has been published at that time. So, up to you to talk about that.
Yes, 2 minutes. So we were really excited because it worked, and we did almost all our patients were done with drill guides. It was easy because we had the funding by Materialise. Anyway, we wanted to get experience, and we got a lot of experience. And Materialise was actually a clever company. From the beginning, they looked for experts. They were not experts in the beginning, but they became experts. So they called that the advisory board. You remember? We were both in the advisory board, plus a lot of people from everywhere of the world. So Materialise got experience because they got input, a lot of input, but the people, the physicians working, got a lot of experience too. So we found it, since we were in the advisory board, we thought, okay, we have to write books, we have to make text, we have to make courses, and that is what we've done. Philippe has written a very nice book on computer-guided implantology. Today you can find maybe 100 books about that subject. And we also, I don't know if you remember, Philippe, we made a surgery guide cookbook.
Yeah.
And you still can find it on the website of Materialise. I found it. It's in a PDF format. It's really describing everything from A to Z, what we knew in 2000, 2002. So it's a little bit outdated, but it's really interesting stuff to look at. Oh, I went too quick. I have to go back, Philippe. Yes, this one. And then I have a very nice anecdote. And it's about this lady. One day I managed with the manager of Nobel Biocare and the Benelux, and I said, you know, I would like to talk to the top management of Nobel Biocare about guided surgery. So he organized, I'm shifting all the time, and he organized a meeting. And I flew to Göteborg, and there was a meeting going on of the top management, and they said to me, wait outside the room because the meeting is still going on. And then after a while, they let me in and they say, you got 15 minutes to explain about guided surgery. Okay. I went in, I did my presentation, 15 minutes, I stopped in time because there was question and answer. And I say, does someone have questions? Silence. Few seconds, and it looked like minutes. Nobody moved. On a certain moment, Eliana Canepa, she stood up and she said, you have to know, we will We are an implant company and we will never be a software company. She stood up and she went away. So, meeting was finished, I have to go back to Brussels. Fortunately, her team made her, said to her, you were wrong because this is really the future. And I think a few weeks later, I got even an apology letter from her saying, yeah, you know, it was too busy that day or whatever. But they acknowledged finally the seed was planted. Materialize was the first, but Nobel Biocare did follow, but they took them several years later before they followed. And of course, in the way they improved it. And you know, Eliana Canepa, and I knew her quite well, and she had a very bad temper, and we called her also the Tina Turner of Nobel Biocare. Philippe, it's back to you. So we started easy, and then gradually we say, can we do this, can we do that? And then we started, and this is such an example of a more complex case you did with one of your colleagues.
Yeah, so we did this case with Philippe, and this was published in 2001. So we started that case in 2000, and it's an historical case where you can see that we've been working with Benoit Philippe, and myself. So he's been doing a LeFort one. He's been making 2 sinus lifts with pieces of the bone that has been harvesting, and this is the position. So what he's doing today, he's doing that simulated on the computer. At that time, it was not simulated, it was done by hand. But this is the history. They need to bring step by step new things. So to have the same curve at the upper and the lower, he's been harvesting bone, and he's basically placing bone at the bottom here. He's been taking it on top. So a few months after, I've been removing the screws. Today, I will not remove the screws, but at that time, I thought that we could have scattered images leaving the screws. So I removed them, but I guess that it's a mistake that we did. We didn't need to do that. And what's interesting is that we've been planning this with the kind of surgical scanner guide that I've been showing to you. And this is what we want. This is what we plan. And this is the result, implant placement with a guide, emergence of the implants in the center of the teeth. And this is what we plan and what we got. So it's exactly the same thing. And this was done in 1999 and published in 2000. So this is one step more, you know. When we started with the 2 implants, okay, now we go further, step by step, doing new things. And then we went to the development of the SAFE system. So the SAFE system was a system to work on the mucosa, or work on the bone, and even work on partial cases. So we had a series of instruments to go from one to the other. And the objective at that time is, you have a 13 millimeter implant, 8.5 and 10 with 1 drill, carefully selected. We can select at different height. And this is what we had in mind, to simplify the process, not to change everything. Use the same drill and do everything.
Use this for pointing because the video does not show it.
Okay, thank you. And then we went to this. This has been published again with Luc. We were so close. It was the history. And this was published in 2007. It's again a partial case where we wanted to avoid the sinus lift. So implantology, guided implantology, helps you to do less than you would have been required to do without guided implantology. This was published in the International Journal of Perio and Prosthetic Dentistry. You see the bone, you see the mucosa, you see the guide. And this is what we have to place. This is a SAFE system kit. And this is the case and the position of the implant and the final result. No sinus lift because we were guided. That's very simple. And this is what we wanted to do. This is the accuracy. And then there was a missing thing also. We could work on the bone, we could work on the mucosa, we could work now on partial cases, but in no way we were able to work on the teeth and on the bone. How to do that? So we did a new step in my company. Arshad Alam Khan, who is taking care of all that, he's been finding a way to have a guide laying on the teeth and on the bone. So we start from this, where you have the bone and the teeth. So you overlay a cast or a digital image of the arch, and you have this. This is the mucosa. This is the teeth. So working on a different software, we are going to link the teeth and the bone. And in this way, we remove that, and we are going to overlay over this, and we are going to make a surgical guide. So now we have the opportunity to see the teeth, the bone, and the mucosa. So it will allow you to have a direct access to the bone in cases you want to do it with a perfect fit of your guide. So you know implantology is not guided and finished. It's growing up every time. This is last year. And you see here the placement of the implant, and you see the guide planning. So it's exactly the same. It's coming exactly as it should be. But for the zygoma part, the important guy is Luc, because he's been inventing the way to place zygoma implant using guides. Luc, talk to us about that.
Yes. Philippe, I have one remark about the previous one. This one. The advantage of working like that is that at the same time you can do bone augmentation, because you have an open flap, you have rigid support, you can put your implants, and you can add some bone material if you want to do that, or LPRF or whatever. So you step really in what we do today, and you can combine it with all technologies we have used.
And there is no contamination when you place implant through the mucosa, because you place it directly inside the bone with no contamination.
Correct. I think from day one, I saw the drill guides. I wanted to use it with zygoma. Why? Because nobody has done it, I don't know, but I just absolutely wanted to do that. So I want to show you some experience we got with that. And this was a patient Philippe and I did together, and Philippe came with his whole team from Grenoble to Belgium, and 2 patients, you remember? 2 patients for the same day. So we did 2 patients, both of them got a zygomatic implant. This is the first patient, which was nicely prepared by Philippe, and you have the bone, you have the soft tissue, you have the teeth set up, and we wanted to place 2 zygomatic implants, 2 pterygoid implants, and 4 standard implants in the front. So it looks like overdone today. 8 implants, it's too much, but at that time it was a normal thing to do. But if you imagine the pterygoids go to the back, the zygoma goes lateral, and the other ones are vertical. So you have all directions for drilling, so it was not possible to make this in one drill guide. We made 2 drill guides for this patient, one for putting 3 zygomas and one for putting 4 standard and 1 zygoma. So we looked a little bit how we could drill it. And you can immediately see that the directions are completely different. Also, the guiding sleeves for zygoma are much longer than for standard implants. For standard implant, they are 5 millimeters. Here we have tubes of 1 centimeter. But you can imagine 1 centimeter on this side, 1 centimeter on the other side, so there's not much room left. It's difficult to access, and that's why we use this special mouth opening, which we normally use for pharyngeal surgery, but we use this just to to have a good exposure. And then the drill guide was fixed with 4 or 5 osteosynthesis screws. So the drilling was done flapless through the mucosa. And this is the view immediately after the operation. So you can have a look how nice the mucosa is. We have put 8 implants in this case, so there's a very little damage on the gingiva. And since we wanted to do immediate loading, Philippe immediately took the impressions and the bite registration. And then it was up to the dental technician to work. Remember, it was 2003. We had no digital fancy things like we have today, so it was the manual way. He had to work during late in the night because we wanted to put the bridge next day. And of course, Philippe, you remember when the technician was working, of course for us, we went to have a good eat and to relax a little bit while the other people were working. So this is the next day. And it's always very rewarding when you see the bridge sliding in and screwing it, and after a few minutes, it's finished. And it's still more rewarding if you look at the patient when she goes before the mirror and for the first time she sees her smiles. It's very emotional for the patient, but also for us, very rewarding to see that. So she got her bridge on 8 implants. So I think this is a feat really to be able to do that. But you could also think people who know zygomatic implants say, how can you do that zygomatic implant with a drill guide? Is this precise or not? Is this the saying from if you have little implants, little problems, big implants, big problems? Let's find out. If we take the postoperative radiograph, this looks very good. This is not the patient, it's not the same patient. This looks very good. But if you look on the other side, there's something wrong. So they should be more or less parallel to each other, but they are crossing. So there is something going on. How do we know that? The only way to do is take a new CT scan or Comin scan and match the postoperative scan with the preoperative planning. Today, with artificial intelligence, it's done in a blink. But at that time, it was hours of work for a technician to match the 2 images. But we did that for 24 patients. We have matched them all. And this is the result. The red one is planned. The yellow one is what was done. And you see that the 2 zygomatic implants are deviated dorsally, so they are what we call in the infratemporal fossa. And if you look at the lateral image, you see the one who is sticking out almost vertically. It's not in the pterygoid bone, but it's in the pterygomaxillary fossa. So this put us back. I was flying high, but it put me back with the feet on the ground. Okay, this will not work. We didn't do drill guides for zygomatic implants anymore. But what is the lesson? I showed you a zygomatic case, but I could show you a standard or whatever case. It means that going digital allows you to make a feedback loop, because you can do your treatment and put it back, project it back on your planning and see what you have done. So this is the learning tool for our own. How can we improve what we're doing? Here, it learned a lot, because it learned me, don't do that again. For other things, okay, you're on the good way, continue, maybe you can refine it if you study well the pre and the post-op. So this is, for me, a really, really good advantage of the digital way. It can be done with almost any treatment, and all the treatments that Philippe will show later, think about that. You can check it, how good it was or how bad it was, and how you can improve. So this is, for me, the big lesson I have learned. And then, of course, we didn't stop with zygoma. Philippe is a really artistic and creative mind, so I think every day he can make an invention. So he made new things, and let's look what he found more.
Okay, so let's look at the development in the dental clinic. So we have, yes,
You point with this and you change with this because
okay,
they are recording from the screen.
okay. So, okay, no way.
It's working. Let me show you.
Okay, so as you see,
Here. You have it.
okay. So as you see, we are working now in orthodontic screws or orthodontic implants, guided. So I showed you already some guides, but now today we are going in many implants at the same time. So this is an example I did last week. You see the implants are planned on right and left side, and each side also in the middle, in the bone of the nose here, and on two parts in the inside. Because when you are putting implants outside, you may push the teeth outside of the bone. So you need to have some anchorage inside also. So we do that, and we make some kind of guide like this. And these guides, you can go through the mucosa directly to the bone, and you tighten the screws inside the bone. So this is working very well. The implants are not osseointegrated. This means that they can be stabilized mechanically, but some of them you will lose them. And if you are lucky, you will not lose too much. But no one can say we wait for osseointegration on implants in orthodontic cases. It's just anchorage. And you have to explain to the patient that. So this was done. And this is the wires which are put all over. And you see the wires are pulling up. And the orthodontist is correcting gummy smile with this. Crown lengthening, I developed that long time ago. This is a case of 2007. And this is again a case where the patient was chewing the gum and she wanted absolutely to change that. She used to come to Dubai from Saudi to be treated. And here you have one implant holding the canine. So it's difficult to pull up the gum and the bone because we will see the implant. So it was a quite complicated case to manage. And we've been managing with software. You see the implant. We have been adding the gum and adding the color of the gum and of the teeth. And this was coming from Materialize at that time. And we don't use it really today, but it's nice to see that we can overlay the color from the pictures of the patient. So this is that, and this is that. And based on the literature, on the study of Gargiulo, you have a space in between the end of the sulcus to the bone, and this space is a biologic space, and you should get that if you want to stabilize the gum at a good level. So we count 3 millimeters, and we are going to make a guide like this. The benefit of this guide that you don't have, several people have been inventing guides, but this guide is special because you see what you do. If you put the gum and you limit at the gum, you don't know where you are. But with this opening, you directly see where you are. So this is better, and we're still using that today. So we can manage the drilling, the reshaping of the bone, but this is not finished. What I do then, not only I work in perio, but I work in prosto, and I make a guide, okay, laying all over the teeth I want to replace, and this will help me guiding the preparation of the teeth. If I want to change the position, this guide will show me what to do. So it's a prosthetic guide and a perio guide. So, and this is the result. I've been preparing the teeth, and this is the before and after. For the patient who has no more gummy smile, and she's happy with this smile now. So we can control that. So what we have been doing also, and I am not doing any root canal treatment, I don't know how to do that, but we had a request for some people to use guides to find the root canals, okay? And we are making guides like this. and this guide is placed on top, and you have a small opening, and when you go inside, you are exactly inside the root canal. No need to look for it, it's directed, and it's working very well. I did not check, I didn't do it, but the people who are doing that, they are very happy because they can very easily find the opening of the canals. Voilà, so you see that you have a variety of things that you can do, and this is interesting, but we need to talk about the future. This is what we've been doing, and we've been doing a lot. But what about the future?
To look to the future, we must look to the past also. So I thought, let's represent what we have done like a tree. And the root is really the CT scan or cone beam scan. Without the scan, we could have done nothing. But we have the scan. And then we have had some major fundamental developments, which is DentaScan, the VIDIAS project, having a material to be printed, the PISA project, making a drill guide. This is really the trunk of the tree. In Latin, I could call it the truncus communis. Everything comes together. And then you have branches coming out. And from the 12 years we have discussed, we have this development. Of course, afterwards, a lot of more will come, but the main is we have prosthetic set up in the planning. We have the technologies of drill guide, which has been refined. In the beginning, it was only one tube. Later on, we could have different diameters of drills going on with the safe system and the multi-drill guide. Then we have immediate smile, which we call immediate loading today. We have psychomatic implants, we have pterygoid implants, we have non-implant related applications like orthodontic anchorage, guide for crown lengthening, and no guide. So you see this tree is really blossoming, and I think we will have more and more branches coming out. It's not for us to develop them, but it's for you to develop them, and I think it will be a very beautiful tree. What about the future? Just a few ideas. Because you have been so long in the past, so we are allowed to think what will give the future. We started with static guiding. Drill guide is an example. So we are evolving to dynamic guiding, to navigation techniques, maybe to robotic surgery. And actually, if you think profoundly about robot is a combination of static and dynamic. It's both together. So it makes sense. It's a logical evolution. Then we will have improved accuracy in the planning. Accuracy means putting the implant where it should be, hopefully staying as long as possible. This is an accurate planning. Accuracy means having all your data for you in your implant planning platform. CT scan, clinical data, radiographs, occlusion scan, whatever you want to put, facial scan, whatever you want to put in it. If you have all those data, you can make a more accurate planning. Then the planning has to be transferred. We have talked about drill guides, we have navigation, we have computer. All those means are developed to increase the precision of the operation. Remember, accuracy and precision is not the same, are two different things. But now we are talking about technical things. This is precision. This will improve. Of course, artificial intelligence is coming. It detects the nerve for us. It makes virtual teeth setup. It orientates the skull. It makes fusion of images. So these applications will develop, I am sure. Our future planning program will be full of artificial intelligence. I'm sure about that. Augmented reality and virtual reality, of course, this will be developed for surgery, for prosthodontics, for dental technician. They all will evolve in that direction. Then for the surgeon, he needs to have actual on-the-spot view. meaning he is operating, and at the same time he is seeing the cone beam of the region where he is operating. He can evaluate pathology, he can evaluate densities or whatever. So this will improve, and this will surely come. We see that already in urologic surgery, where they really have visual integration. Then we will have integration with all types of software. Now we have a software for the surgeon, a software for the prosthodontics, a software for the laboratory, whatever, for the manufacturer also. This will smoothly integrate. Some software are already doing that, but they will all follow and will get more and more integrated so that we have more information. Of course, don't forget teledentistry in our world. With Corona, it became very important to be able to work at distance, to have radiographs for your planning, even to do a planning on a distance, prepare everything before the patient comes, and you can give them the explanation. And then finally, the monitoring. This is looking for, in the future, we will have our planning system, which is a very, very small thing, but we have all our software for monitoring the health of the patient, and so on. Many, many things will be integrated. The more data we have, the more able we will be to monitor and follow up our patient. Maybe our implants will get connected one day. Who knows? It could be possible. You can follow them up. If you see something wrong, you can recall your patient. I think this will be some views for the future. So quickly, I just wanted to give you an idea of what could be possible. I would like to conclude with this quote. We learn from the past, embrace the future, and live in the present. The past is important. It's not because we are old men, but the old men have done something. It's maybe in the long run not important, but at least we started something. So it's very interesting to look what the old men have done and to learn from what errors we have done, because you don't have to make the same mistakes again. We did them for you, so make other mistakes maybe. Live in the future, I think embrace the future. The technology is going really, really, really quickly. For us, or for me especially, it's sometimes difficult to follow everything which is going on, but I try. But we need to embrace the future so that we can see what is happening, to improve and to displace the boundaries of what we used to do, because we will be able to do more and more. Of course, we may not forget to live in the present. The present is today or Monday. When you get in your practice, you have your patient. This putting all your effort in improving the treatment of your patient, doing everything for your patient. This is what happens today. But today, at the same time, the future is built, little step by little step. And then I think more or less this is the way we will advance. When we look back, after our many, many little steps, we see when we look back that we have made the way. There is some way going on. We don't realize that day by day, but when you look back after 25 years, you can say, okay, we did something from the first little guide which we pushed with the finger. Look where we are now, and I think we are very proud of what the technology has brought us today. Philippe. You can kick me out.
Yes, no. I really would like to tell you that this is a school of humility. You need to be humble on what you do today, because you know that this will be erased by the history. The future, we are in a wrong science. So we will improve the science every time, doing more things, and we will build up the future. If we believe we are the best in the world and we stop thinking, okay, we are dead, okay? Our place is not here anymore. We need to be very humble to go forward and know more about that. We forgot to talk about the immediate smile, which is a bridge which is fabricated before the surgery without taking one impression. Everything is digital. This was done a long time ago. And finally, I would like to thank you. if you want to end with that. To thank you, Dr. Panos, Professor Panos, who has been so kind to organize all this Congress. It's been very difficult to do it, and I really thank you for what you've been doing in an excellent way. Thank you very much. No question?
Any question? I would like to focus on what it was said before about the past. The past is experience. I think I'm heard. We need to count. We need to be based. Doesn't work. Technology doesn't always work. And that we have to keep in mind. This one, it does work. The past is very important, most important, because number one, history gets repeated. And secondly, because this is experience. What we see today, it would not be possible without all what we saw today. Maybe, as it was said before, there were some, if you look at the pictures, they look a bit old, but it's nothing different than what we do today. And it took 25 years, if not more, to reach this stage. The CAI Academy is an opportunity, we will discuss it a bit afterwards too. The CAI Academy was the scientific society that established scientifically the topic. Commercially, maybe it was done before in another way, but scientifically it was done by the CAI Academy. And it was always a closed, let's say, group. Many times I have heard that people were complaining why this technology was not more widely known, why it wasn't spread. That is a mistake. It was always available and it was always spread. But we also need people to search for it, to search for the innovation, to search for the new things. Innovation is not what we see in the media. Innovation is not what we see in the journals. In order to reach a journal, there is a long way until we reach there. So thank you very, very much. I hope if there is any other question, now is the time. Yes?
Yeah, first of all, I would like to thank you very much for the presentation. It was very exciting for me to where we begin and where we are now. Actually, it's...
If you can speak a bit louder, because we don't have yet the microphone.
Luckily, we have now digital technologies. I mean, when I did my first case in Turkey, it was early 2000 or something like that. And I was planning the case and I was sending to Belgium to Simplant to obtain my guides, and I was waiting almost 15 days to come back my guides. But now we have printers in our office. We are just basically taking, having our CT scan and planning and printing and doing it. And both of you is very experienced. I mean, what makes you excited now? I mean, if you look at the past, what is the most exciting part we are in now in digital dentistry?
Ready?
What excites me most is the immediate loading. We do a lot of what we call one-shot treatments. We are doing more and more retreatments. I think half of my patients already have implants. Peri-implantitis, they lost implants. And they come back. They are used to having something in their mouth. They know they have problems, but they want the treatment. And they say, I know you can do immediate loading. Can you do everything in one shot? Removing implants, putting implants, taking impression, putting the bridge, doing both jaws at the same time in one day. This excites me. The computer will help me. The computer is not able today to give me the whole pathway I explained, but I use it like a tool. I use guiding like you use a car to go from A to B, and then you can take your bike or you walk a little bit and then you reach your destination. lots of things I do are combination of digital and old-fashioned manual, because it's something also practical to do something. And being able to combine and to switch from one treatment mode to another, this excites me. This is really something interesting. I am experienced, but I need an experienced dentist or prosthodontist. I need an experienced dental lab, and having the three together, this gives us power because we work together. And this is for me the most exciting.
About me, I believe that the satisfaction of the patient is the center of what I'm doing. I want the patient to be satisfied. You remember I've been showing you a case where we in the early time, we've been placing implant without making a sinus lift. My patient appreciate if I can find a solution reducing the surgery. They appreciate the solution when we reduce the bone grafting. All these they appreciate, okay? And based on the imaging system, we are allowed to do that. For the future, immediate implant placement, we made, you remember, we've been making a Dr. James to automatically place the implant. And this was not working very well, but I have ideas, you have ideas, you are on that, I am on that. We are going to build up something easier to automatically place the implant. You will have less and less to do. The computer will do that. And this is clear that this is the future for a better service to the patient. I don't put the computer-guided implantology in the center of my research. I put the patient in the center of my research.
Hello, thank you. I want to ask you, and thank you for your wonderful speech, but I'm a little bit worried about artificial intelligence now. What we did in 30 years is to use our new software that we were guiding for the result. What I see now, it's already now you can send your organic news, not as a dentist, as a patient, somewhere in the web, and get back the treatment plan for your mouth. For me, this is dangerous because artificial intelligence that we learned how to do that is coming back as a software and not as a doctor. So I think that CAI Academy and all the scientific institutions we have, they have to control what's going on. If not, the problem could be that artificial intelligence that we learn with the deep learning, they substitute the doctor. I'm afraid. What can I tell? What can you tell me?
You are absolutely right. When you use ChatGPT and you believe the answer of ChatGPT, be careful. Some answers are good, some answers are not good. And it's exactly the same. If they make a diagnosis, a treatment plan and all that, don't trust. So yes, in the future it will be better and better, but at the beginning we will have big mistakes. But again, I mean, building up the future started with the first case. You know, he's been doing a first case, putting a kind of piece of metal to put drills. It was risky. It was risky. But if you don't take risk, you will not go forward. So yes, we take the risk and we know that there is a risk. If we take the risk and we believe like it's a magic tool, oh, bad things will happen. I agree with you. Be careful.
Thank you.
But I also think that some aspects of artificial intelligence are very useful. For example, I'm used to use DTX from Normal Biocare. And there is some piece of artificial intelligence because it draws the nerve automatically. And in the beginning, I was not sure. Actually, for many years, my wife has always been drawing the nerve in the scan. She's very expert at that. She knows that very well. So she always verified, and she did it. And by the end, after 20 cases, we say it doesn't make sense because the program does it in 5 seconds. And she has 15 minutes to do that because it has to do segmentation and so on. So in these aspects, artificial intelligence is useful. The program, for instance, also takes the clinical pictures in and takes the apicals in and put them automatically. So when you click on a tooth, you get the clinical image. You have to do nothing. It's automatically with artificial intelligence. So for me, artificial intelligence is a slave. It's not my boss, but it's a slave. But it can save us a lot of time. So I think these are the types of applications we should look for. Not, as you said, give me a planning. What does he know about the patient? Nothing. Is a Bruxist or not? Things like that. The program doesn't know. We'll give you a planning and it will be wrong. So this is the wrong question to artificial intelligence. So the artificial intelligence is there, but we have to learn to ask the correct questions. I think this is what we or the organization have to learn. That's